Good morning, sir. Am I audible?
Yeah, you are audible. Please go ahead.
Good morning, all. Today's case presentation, a 63-year-old female from Alwar, housewife, presented with chief complaints of yellowish discoloration of eyes and high colored urine since 3 months, pruritus since 3 months, fever 3 months back, loss of weight and appetite since 3 months. History of presenting illness. Patient noticed yellowish discoloration of eyes and high colored urine since 3 months. Insidious in onset, progressive in nature, not associated with pain abdomen, not preceded by any prodromal symptoms, and not associated with ecolic stools. Associated with pruritus since 3 months, generalized type of pruritus present throughout the day, disturbing sleep and lifestyle. History of fever 3 months back, present for 3 to 4 days, high grade, intermittent, associated with chills and rigors. History of loss of appetite is present. History of loss of weight is present, which is not quantifiable. No history of vomiting, hematemesis or melena, abdominal distension, chest pain or hemoptysis, no history of headaches, seizures or blackout, and no history of back pain or any bony pain. Following these symptoms, patient was evaluated and underwent ERCP and stenting on January 10th of 2023. After which, patient was relieved of pruritus and jaundice was in decreasing trend. Patient was advised surgery, following which patient had not come for the follow-up. From the past 1 month, patient again had painless progressive jaundice with pruritus and no episodes of fever from past 1 month. Coming to the past history, no history of diabetes mellitus, hypertension, tuberculosis, asthma, and no past surgical history. Coming to the personal history, patient consumes mixed diet, sleep is disturbed, appetite is decreased, regular bowel and bladder habits, no history of alcohol consumption or smoking. Family history, nothing contributory. This is my history, sir.
You please summarize it.
Summary, 63-year-old female with no comorbidities, with painless progressive jaundice since 3 months, with intractable pruritus, with features of cholangitis and loss of weight and loss of appetite, underwent ERCP and stenting 2 months back. Patient again developed similar complaints from past 1 month, secondary to stent block. I want to give a differential diagnosis, keep a differential diagnosis of periampullary carcinoma, hilar cholangiocarcinoma, carcinoma gallbladder, and carcinoma head of the pancreas.
So you have 4 differential diagnoses and all are malignant, right?
Yes, sir. Yes, sir. Malignant obstructive jaundice, I want to keep as a diagnosis.
Right. So without going into the individual TD,
Okay,
just want to know why do you think malignant? First of all, it is a obstructive jaundice, and second, it is a malignant obstructive jaundice.
yes, sir. Mainly because, sir, there is no pain, painless progressive jaundice is there. And
Right.
Patient has loss of weight and loss of appetite, which points towards the malignancy. And coming to age of the patient, it also favors malignancy, sir, than benign pathology. That's why I want to keep malignant pathology as my DD, sir.
And what are the symptoms or presentation which is going against malignant obstructive jaundice?
Patient presented with fever, sir, cholangitis,
Right.
which is usually seen in benign pathologies rather than malignant pathologies. That is the point which goes against malignant pathologies.
Why can't it be CBD stone or cholangitis because of root ulcer?
CBD stone usually will have pain, sir.
Mm-hmm.
which is not present in this case, and no past history of any biliary colic earlier. If patient is having any gallstones or any cholelithiasis, patient would have presented with biliary complaints earlier in the at an earlier time, which
May
is
or may
not.
not be. Not necessarily.
Sorry, sir.
Not necessarily. Patient will have biliary colic in the past.
Yeah,
Can
yeah, sir. Not
suggest that patient is
necessary.
having cholelithiasis at present. So it may be the first
Yes, sir.
presentation, right?
Yes, sir. Yes, sir. It can be first. Usually, pain will be present, sir, in choledocholithiasis, which is not present here, and um, loss of weight and loss of appetite, which are present, points against the benign pathology.
Because loss of appetite may be there in some benign conditions. What are
Yes, sir.
those benign conditions?
Yes, sir. Loss of appetite can be there.
Even loss of weight may be there.
Long-standing
Can
care,
you
loss of weight can be there.
enumerate some benign conditions?
For these symptoms,
Loss
sir.
of loss of appetite and loss of weight.
Long-standing cholangitis can have loss of weight and loss of appetite.
Is there any entity called chronic cholangitis?
Chronic cholangitis, no, sir. Repeated episodes of cholangitis with intermittent relief of symptoms.
The loss of appetite may be there in a benign condition like viral hepatitis,
Sir.
right? So just because patient is having loss of appetite, you cannot simply rule these benign conditions totally out of your differential diagnosis. Just
Oh,
based on this thing, loss of appetite, right? But
okay.
at the
Yes.
same time, you have to look at some other symptoms.
Yes,
So
sir.
you have a presentation of jaundice,
Yes,
right?
sir.
Then
Yes,
you
sir.
have to look for other associated symptoms, and then you have to look for alarming symptoms,
Yes,
right? You
sir.
have mentioned in your history there was no prodromal symptoms.
Yes, sir.
So at this stage, I would like to know what are the prodromal symptoms you were looking for. And second, the same time you mentioned there was no history of blackout or seizures. So what is the significance or relevance in the context of jaundice, blackout and seizures?
Yes. Yes, sir. Uh, First, sir, prodromal symptoms usually nausea, vomiting, myalgia, malaise. These will be there, which will be present before any viral infection or viral hepatitis.
Yeah, before the appearance of jaundice itself. That's why there are prodromal symptoms.
Yes, sir. Yes, sir.
Got the point. But patient with acute cholangitis might be having nausea or vomiting, but usually the same time when the patient develops jaundice or after the development of jaundice. But the
Yes, sir.
prodromal means symptoms
Before
started with
the.
these non-specific symptoms.
Yes,
Got the
sir.
point?
Yes, sir.
So the sequence of development of symptoms becomes important.
Yes, sir. Yes, sir. So
Right?
these were
Joint pain is also
not.
there. Joint
May
pain,
I interrupt, sir?
anorexia, myalgia, right? And what is the significance of blackout or seizures in the context of your
Sir,
obstructive jaundice
I
or
was.
jaundice?
Yes, sir. I was just asking metastatic history to rule out any metastasis. Uh,
How
any.
commonly in your routine OPD workup, patient
Yes.
present for the first time with seizures or blackout or even having the coexisting seizures?
Yes, sir. It's very rare, sir. Just for completion of the
History.
uh, history I have taken, sir. Yes, sir. Malignant metastatic history.
May I interrupt, sir?
Sure, sir.
This is Dr. Rajendra Desai from Hyderabad. See,
Morning.
age alone is not a contraindication for CBD stones. At the age of 70, the incidence of CBD stones or periampullary carcinoma are similar. So please don't give age as an implication because it starts at around 40. It can go to up to 60 years of age, we see CBD stones. Biliary
Okay, sir.
colic, I understand. Biliary colic would have preceded complications, but not always.
Sure.
I totally agree with sir. Actually, when you elicit history and
Yes.
when you make the differential diagnosis, right? So there
Yes.
are complaints, there are key complaints, and there are combination of key complaints, right? So it is
Yes.
like when you do the PubMed search, when you enter the keywords, right? So if you enter one keyword, there are many publications that comes out on PubMed research, okay, for your search.
Yes, sir.
Similarly, based on single symptom, there are so many differential diagnoses. So you have to combine all those key complaints or key symptoms so that you can narrow down on your differential diagnosis.
Sure,
Got
sir.
the point?
Yes, sir.
Like you are doing a search on the PubMed literature search, more specific keywords you combine, then you get the selected article. The same way you get the selected differential diagnosis. So, like sir is saying, age alone cannot rule out benign or malignant condition, but you when you combine age with other symptoms, got
Yes,
the
sir.
point? Like
Yes,
age
sir. Yes.
plus painless progressive jaundice plus anorexia plus weight loss, then the indication of having the malignant disease becomes higher. But if you see only isolated age, then it may not be that specific,
Sure.
right?
Yes, sir.
Okay. And so basically, you can just summarize in two sentences what is the overall presentation of this patient.
Painless progressive jaundice associated with loss of weight, loss of appetite, and intractable pruritus with no comorbidities. I want to,
With history of endoscopic biliary drainage
yes,
with
sir. With,
recurrence of symptoms after
yes,
initial partial response, right?
yes,
But
sir.
the entire sequence started with cholangitis, right?
Yes, sir. Started with cholangitis.
So how commonly malignant obstructive jaundice present with cholangitis? And it
Um,
is just did you confirm again that it is truly a painless progressive jaundice when the patient actually had cholangitis?
yes, sir. Yes, sir. Patient didn't had any pain, sir, as such, pain abdomen.
It was only fever.
Yes, sir. Jaundice and fever, sir, mainly.
So this patient presented to some other center, right?
You
Then patient came to your center,
right. Yes, sir.
right? So in retrospectively, how did you make the diagnosis of cholangitis?
Sir, patient was having progressive jaundice and fever episodes were there
Mhm.
with loss of appetite also.
What is the diagnostic criteria of cholangitis, acute cholangitis?
Um, Jaundice, fever,
See,
and
in other words, what is Charcot's triad and Raymond's
yes, sir.
pentad?
Pain, fever, and jaundice, sir. Cholangitis.
So just because patient was having jaundice and fever, can you
Yes,
label that thing as a cholangitis?
um,
What is
in
Tokyo criteria, Tokyo guidelines? What is the defining criteria for cholangitis as per Tokyo guidelines?
yeah,
How do you diagnose cholangitis based on that guideline?
fever, sir. Presence of fever, um, more than 100.4 degrees, and increased bilirubin, and associated with
See,
increased
when
WBC
you
count.
see, there are three components. One
Yes, sir.
is biliary stasis,
Yes, sir.
right? Second is inflammation. So inflammatory markers should be increased,
Yes, sir.
right?
W is
And biliary stasis should be extrahepatic. So you can have dilated system. To assess that dilated system, you have to have the imaging, at least ultrasound. And
yes, sir.
third is the cholestasis. You have to have the LFT. Got the
Yes, sir.
point?
Yes, sir.
So
Yes,
if
sir.
you have two component, it is suspected cholangitis. If you have all three, you have a confirmed cholangitis. And then depending on the different criteria, you can have mild, moderate to severe cholangitis.
Yes, sir.
But just to have a diagnosis of cholangitis, you have some basic, at least two out of three criteria for suspicion or confirmation. Got the
Yes.
point? Just
Yes, sir.
having jaundice and fever does not mean patient is having
Cholangitis.
cholangitis. Patient might be having hepatitis.
Mhm.
Patient might be having liver abscess. Patient might be having infected hydrated cyst.
Yes, sir.
Got the point. That's why I'm
Hmm.
asking ki, how did you come to the diagnosis of cholangitis in retrospective? At this stage, when you have not gone through the patient record.
Yes, sir. Yes, sir. Yes, sir. Those
So, what is
reviewing
a single important uh, point in history that gives the clue that patient actually had or having surgical or obstructive jaundice? I would not say surgical; it is the obstructive jaundice. What is a single?
pruritus, present of pruritus.
So, there is a history of intervention. ERCP.
Yes, sir.
You
Yes,
have
sir.
mentioned.
Yes,
Patient
sir.
underwent some endoscopic management and some stent or belly drainage was done.
And
Stent was placed and patient had respond to that intervention.
yes,
Patient will not have such kind of relief or intrahepatic cholestasis.
yes, sir.
So that gives the clue. Correct.
Okay, sir.
See, painless progressive jaundice is a clue for the malignant etiology of the obstructive jaundice.
Sure.
Got the point. But the entire sequence
Yes,
started with the cholangitis,
yes, sir.
apparently cholangitis, right? Presumably patient had cholangitis, but actually it started with a fever, jaundice,
Yes, sir.
right?
Yes, sir.
So this point, because you have not gone through the investigations, you don't know whether it is a obstructed system, dilated system, or what was the imaging finding as such, what was the LFT pattern as such. But some kind of endoscopic intervention that led to relief in symptoms with a recurrence of symptoms after some times that indirectly give clues that patient had obstructive jaundice, right?
Yes.
Then comes to the differential, what could be the cause of obstructive? Then you have enumerated based on those other symptoms,
Okay,
but
sir.
still you have not mentioned some of the benign causes.
May I
Benign,
Uh,
interrupt, sir? Yeah.
sir, please.
Yeah, you have not considered parasitic disease as the cause of jaundice at all. Ascariasis can produce similar symptoms, mimic a CBD stone, and it causes obstructive jaundice. Phalangitis is early, so you should consider ascariasis. In your history taking, you have not asked a history of parasitic disease or history of travel outside the country.
yes, sir.
So please go ahead with the examination.
Shall I proceed?
Yeah, please.
General physical examination. My patient is a 63-year-old female, averagely built and nourished, with height of 160 centimeter, weight of 50 kg, 52 kg, and BMI of 20.3. ECOG of 1. She is conscious, cooperative, and well oriented to time, place, and person. Pulse rate is 70 beats per minute. Blood pressure is 116 by 80 millimeter of mercury. Respiratory rate is 18 per minute. Saturation, she is maintaining 99-100% at room air. Icterus is present. Scratch marks noted over trunks and both upper and lower limbs. There is no clubbing, left supraclavicular lymphadenopathy, or pedal edema. There is no peripheral signs of CLD. Examination. Shall I continue, sir? Examination of the abdomen. Inspection. Abdomen is flat.
Please go
Umbilical.
back. Please go back. General examination. The next slide. Next slide.
Sir.
So you have mentioned no peripheral signs of CLD.
Yes, sir.
So two things. What are the different peripheral signs of CLD? And second, what is the significance in this patient
Okay, sir.
of these
First,
signs? Why did you look for these peripheral signs of CLD? Did you suspect CLD?
no, sir. In case of jaundice, I just want to see for any CLD features during examination. That's why
So
I mentioned that, sir.
all patient with obstructive jaundice, you have to look for peripheral signs of CLD, or there may be some patients in which it can be omitted or specifically looked for. Just asking.
Uh, As such, in cases of jaundice, it's better to look for any signs of CLD.
Like
Signs from head to toe, if become jaundice, presence of jaundice, malar erythema. Sorry.
see, peripheral sign of CLD, right?
Yes, sir.
So patient presenting symptom is jaundice.
Yes, sir.
So how it will differentiate, indicate towards CLD?
No, other signs I want to see, sir.
Like
Like malar erythema, spider nevi, gynecomastia, loss of chest and axillary hair, and Dupuytren's contracture, palmar erythema, flapping tremors, abdominal distension, ascites, caput medusa, and testicular atrophy, pedal edema, these things.
the period edema is already, it is not there,
It's
right?
not there. Yes,
So
sir.
if it is there, it will indicate towards CLD or something, some other problem.
No, sir. Even malnourishment can have.
Second, flapping tremors you mentioned,
Yes,
right?
sir.
So you mentioned that patient was conscious oriented, ECOG1.
Yes,
So
sir.
do you expect flapping tremors,
No, sir.
right?
Yes, sir.
So at what stage of CLD you will find such peripheral signs like gynecomastia
Uh,
or parotid enlargement, tropitan contracture? Patient is non-alcoholic.
yes, sir.
So do you get tropitan contracture in non-alcoholic advanced CLD?
No, sir.
That's why I'm saying he just go blindly with all the features of CLD. You have to
Okay.
look at the context, right?
Yes, sir.
Patient is male, alcoholic, chronic alcoholic. There had been past history of jaundice or edema, or there was some suspicion of GI bleed or ascites, CLD. Then specifically you have to look for all signs,
Okay, sir.
right? At the
Yes.
same time, if there is a first presentation, female patient, no history of any risk factor for CLD, or there is no chronic cholestasis, right? That suggests that patient might be having CLD. So don't just
Okay.
enumerate all signs. There are a
Okay.
number of signs which indicate the etiology of CLD also, like alcoholic versus non-alcoholic CLD. Got the
Okay.
point?
Yes, sir.
A patient is totally conscious, oriented, right?
Hmm.
Oriented to time, person, place, everything. Do you expect features of hepatic encephalopathy?
No, sir.
No,
No, sir.
right? So you have to don't just enumerate all such things. You have to see the context of your case.
Okay,
At
sir.
the same time, I would suggest that when you do the complete examination, right? Suppose on examination, abdominal examination, you find splenomegaly.
Yes, sir.
You don't expect in a head of pancreas any very uncommon rare situation, right? But
Yes.
if you find some features of portal hypertension, then you have to go back to look for the cause of this thing. So the workup or history taking for the CLD may be part of that retrospective evaluation that
Okay,
you
sir.
do after your exam.
Okay, sir.
Because in such patient, you are suspecting malignant obstructive jaundice. The jaundice and edema or even ascites may be part of the same malignant process.
Yes, sir.
So they will not indicate the underlying CLD. But at the same time, if you have splenomegaly, got the point?
Yes,
Or
sir.
you patient is alcoholic, there is a gynecomastia suspected. This is testicular atrophy. I really doubt on clinically you will actually go for and see that thing. But there is a pituitary enlargement. That then combination of these features will increase the suspicion of underlying CLD at the same time. You can
Yes.
have malignant obstructive jaundice in HCC also
Ah,
on the background of chronic liver disease, right?
okay, sir.
There may be
Yes,
no
sir.
apparent risk factor like alcohol or other viral etiology. Patient might be having non-alcoholic fatty liver disease. What's the point? So just
Yes, sir.
don't enumerate all the thing at this stage, not like MBBS or MS.
Okay.
You
Okay,
have to
sir.
see the background and context, so then you can justify your assessment part,
Sure.
right?
Yes.
So what is the significance of cyanosis and clubbing in the context of obstructive jaundice?
Cyanosis, as such, there is no significance, sir. Clubbing, chronic malnourishment can have clubbing, but 3 month history, it's very unlikely to have.
All right, please go ahead.
Any associated COPD, other things, clubbing can be present, but patient doesn't have any history like that.
Right. Please go ahead.
Yes. Inspection, sir. Abdomen is flat, umbilicus in central position and inverted. All quadrants move equally during respiration. No mass, scars, sinuses, engorged veins, pulsation and peristalsis seen. Hernial sites appear normal. No renal angle fullness and external genitalia appears normal. Palpation. Abdomen is soft and no local rise of temperature. Non-tender. Gallbladder is palpable. 8 centimeter lateral to midline, just below.
Can I interrupt one thing?
Sure.
What is the significance of like no local rise of temperature?
Yeah. Yes, sir. Here, as it's just
can you think of
during examination I have mentioned, sir.
Can you think of portal pyemia of any cause? You would have fever, you would have jaundice.
Portal pyemia, usually pain will be present, sir.
Again, not necessarily.
Okay, sir. As
go ahead, please.
Gallbladder is palpable, 8 centimeter lateral to midline, just below right costal margin. Globular in shape, smooth surface, non-tender, well-defined margins. All margins except upper margin well made out, firm in consistency, side-to-side mobility present, and moves with respiration. No other mass or organ palpable. Hernial orifices normal. External genitalia normal. Coming to percussion, liver dullness starts at 15th costal space. Liver span is 12 centimeter. Dull note over gallbladder, which is continuous with the liver dullness. Rest of the abdomen is resonant to percuss. Auscultation, normal bowel sounds are heard. Per rectal examination, sphincter tone is normal. No mass felt. Mucosa normal. Fecal staining of finger present and no blood in the stools. Examination of respiratory system, bilateral air entry equal, normal vesicular breath sounds present, no added sounds. Examination of CS and CNS are grossly normal. That's my examination findings.
Summarize, please.
Sir, summary. 63-year-old female with no comorbidities, with ECOG of 1, with painless progressive jaundice since 3 months, with intractable pruritus, with features of cholangitis and loss of weight and loss of appetite, underwent ERCP stenting 2 months back, and patient again developed similar complaints from past 1 month, secondary to stent plug. She is ectric with scratch marks and distended gallbladder on examination. I want to give a diagnosis of malignant obstructive jaundice on this, sir, with my differential diagnosis being periampullary carcinoma, CA head of the pancreas, and carcinoma gallbladder.
Why do you have periampullary carcinoma so prominently as your first in all the diagnosis? Is it that common?
Carcinoma head of the pancreas, sir?
No, periampullary carcinoma.
Because it is a painless progressive jaundice, I'm keeping it above, sir.
That will be the same case with the CA head of the pancreas.
Yes, sir.
Also, mid-CBD cholangio, unless there is fever, there will not be pain. And in this case, fever preceded the pain.
Sir?
In a patient with cholangiocarcinoma of the mid-CBD
Yes, sir.
or of hilar cholangiocarcinoma, pain is usually seen once there is cholangitis.
Yes, sir.
And in your history, you said fever was the presenting symptom.
Yes, sir. Jaundice with fever. Because CA head of the pancreas, sometimes it's associated with pain. I want to keep periampullary above CA head of pancreas.
What is periampullary carcinoma anyway?
Periampullary carcinoma are group of carcinomas occurring 1 to 2 centimeter, constellation of carcinomas which occur 1 to 2 centimeter around the ampulla, which consists of distal cholangiocarcinoma, duodenal adenocarcinoma, ampullary carcinoma, and pancreatic head carcinomas. 2 centimeter from the ampulla.
So out of these four entities,
Yes, sir.
which you think is maybe present in this case? Because in periampullary carcinoma, there is a pancreatic head component also.
Yes, sir.
At the same time,
Yes, sir.
second DD is carcinoma head of the pancreas. So how
Yes, sir.
pancreatic malignancy in the purview of periampullary carcinoma different from carcinoma head of pancreas in terms of presentation like this?
Periampullary carcinoma it, presents early, sir, because biliary obstructions will be early.
So I'm just trying to ask you that you mentioned periampullary carcinoma. So out of these four entities, which one do you think is present in this case? Like I would ask you whether DD in periampullary carcinoma.
For this case, sir.
In terms of probability, yes. You mentioned periampullary carcinoma, then C head of pancreas, but there are four
Yes,
entities in periampullary carcinoma. Which one
yes,
do you
sir.
think remain the number 1, 2, 3, 4 in this case in terms of DD? If you make the sub DD of
Pancreatic only.
periampullary carcinoma,
Pancreatic only, sir.
first is pancreatic,
Yes, sir.
and second is also pancreatic.
Yeah. Uh, in this case, I want to keep ampullary and distal cholangio, sir.
Just tell me, in the context of obstructive jaundice, if you
Okay.
have intense pruritus,
Okay, sir.
you have mentioned painless progressive jaundice, but you emphasized on the intense pruritus, right?
Yes, sir.
So, what could be the causes of such intense pruritus in terms of etiology, not the mechanism of pruritus?
Uh,
Means it is common in pancreatic malignancy, it is common in biliary tract malignancy, it is common in ampullary malignancy, because all these three present with obstructive jaundice.
yes,
But
sir.
if you have intense pruritus, what does
Yes.
it indicate?
It's mainly biliary pathology.
Maybe, right?
Yes, sir.
So, in the context of those combination, out of
Yes.
periampullary carcinoma, which one do you think might be more common?
Biliary ones.
More likely, more likely.
Yeah, distal cholangios.
First, you have said it is pancreatic, then you said it is ampullary. Now you are saying it is lower end cholangiocarcinoma.
No, sir. I thought you asked among the periampullary, which is the most
No,
common.
but this patient is having pruritus. Na?
Yes, sir. Yes, sir.
In this patient, I am asking about this patient only.
Okay, okay, sir. In this patient, I want to keep distal cholangio on this.
Then ampullary,
Yes, sir.
then pancreatic,
Yes, sir.
and duodenum, no.
Duodenum, no, sir.
Why?
It can be possible, but Malina histories and hematemesis history is not there.
It is more common.
Usually not more common, sir, but one of the characteristic association with that.
It may be there in ampullary also.
Yes, sir.
It may be there in pancreatic head infiltrating into duodenum also.
Yes, sir. Can be possible, sir. Duodenal
The
also.
possibility is always there, but
Yes.
you rightly said that it is basically
And
just in terms of likelihood, na? Which one may be
biliary
more common,
obstruction is not that much in
less
duodenal.
common.
Yes.
And why this carcinoma gallbladder? Is it a
Uh,
palpable gallbladder or it is a gallbladder mass?
no, it's a palpable gallbladder only, sir. Even carcinoma neck cancers can have palpable gallbladder.
Right.
That's why I have kept that also, sir. But below C8 of pancreas.